Today, we're going to take a surgeon's eye view of a really complex topic, congenital vascular malformations. Let's dive right in.
So I want you to imagine this. What if the very blueprint for your body's blood vessels had a mistake in it from day one? That's really what a vascular malformation is. It's not something you catch, it's not a tumor that suddenly starts growing. It's a structural flaw that's been there from the very beginning.
Now, for the longest time, the biggest challenge in treating these things wasn't a lack of surgical skill. Believe it or not, it was a problem with language, a simple but really dangerous confusion over what to even call them.
And this really gets to a fundamental truth in medicine, You can't treat what you can't accurately name. For decades, it was just this mess of confusing terms. And that meant patients would get the wrong diagnosis, and because of that, the wrong treatment, sometimes with absolutely devastating results.
Okay, so the first huge breakthrough was making this critical distinction. On one side, you've got vascular tumors. These are actual growths caused by cells multiplying when they shouldn't be. You can think of it like a production flaw. But on the other side, you have vascular malformations. These aren't growths at all. They're just errors in how the vessels were built in the first place. It's a plumbing issue, not a production issue, and that changes absolutely everything.
So how did the medical world move from total chaos to clarity? Well, they created a brand new blueprint, a classification system that finally brought some order to all this. Let's take a look at how it works.
This clear definition, it sounds simple, but it was a complete game changer. A malformation is there from birth, and, this is the key, it grows proportionally with the patient. It doesn't just pop up out of nowhere and start multiplying on its own like a tumor. This one distinction guides every single treatment decision.
And the idea that unlocked everything was honestly brilliantly simple. It was to categorize these malformations by the speed of the blood flowing through them. That's it. Are we dealing with a slow, low-pressure traffic jam or a dangerously fast, high-pressure freeway?
This is just a perfect way to picture the two main categories. You've got your slow-flow lesions, which are kind of like a swampy, backed-up bog where fluid just pools and moves really sluggishly. Think capillary, lymphatic, and venous malformations. And then you've got the fast-flow lesions, which are the exact opposite, a dangerous, high-pressure short circuit in the wiring. The classic example here is an arteriovenous malformation, or AVM. So with this clear map based on flow, surgeons could finally start developing targeted strategies. Let's first dive into how they handle the challenges of those slow flow malformations.
A great example to look at is the lymphatic malformation, or LM. It's basically a spongy mass made up of abnormal lymphatic channels. But even within this one category, that new blueprint gives us even more crucial details.
See, a surgeon needs to know, are the cysts that make up this mass large, what we call macrocystic, or are they super tiny and spread out, microcystic? The answer completely changes the game plan. Large cysts can often be treated with something called sclerotherapy. It's an injection that basically makes them shrink. But those tiny, diffuse cysts, they almost always need to be surgically removed.
And that right there is the whole point. This isn't just about putting things in neat little boxes for the sake of it. This simple act of classification creates a direct logical path from a precise diagnosis to the most effective treatment possible. It's the roadmap. Okay, let's pivot to the other side of that map, to the much more dangerous category. This is where surgeons are often racing against a high-pressure system that can cause some serious damage. Arteriovenous malformations, AVMs, are the classic fast-flow lesion. What happens here is you get a direct connection between a high-pressure artery and a low-pressure vein. It completely bypasses the tiny capillary network that normally acts like the body's speed bumps. The result is this violent, high-pressure circuit that can lead to awful pain, bleeding, and can even strain the heart to the point of failure.
So how on earth do you defuse a ticking time bomb like that? With a really clever two-step approach. First, specialists go in and perform an embolization. They essentially block the main arteries that are feeding the AVM. It's like cutting off its fuel supply. Then, just a couple of days later, once the AVM is weaker and less likely to bleed, a surgeon goes in and removes the central knot of vessels, which is called the nidus.
You might be asking, okay, why the complicated two-step dance? Why not just go straight to surgery and cut it out? Well, there's a very, very good reason.
The reason is this number. For certain types of AVMs, the recurrence rate can be as high as 81% if they're not treated properly. See, if you just tie off the arteries without removing the core, the AVM is smart. It'll just find new blood sources and come roaring back.
You have to remove that central nidus completely, and this two-step approach is the safest and most effective way to get it done.
So whether we're talking about a slow flow or a fast flow problem, when surgeons decide to operate, they aren't just cutting. They're following a very clear philosophy, a set of guiding principles for how and when to step in.
And here's what that philosophy looks like. The primary goal is always to improve function, to relieve pain, to restore mobility. Yes, how it looks matters, but function always comes first. Surgeons are incredibly careful to preserve vital things like nerves, and they plan ahead, knowing that some of these complex cases might take multiple surgeries over time. It's this constant, careful balance between removing the problem, preserving what's important, and thinking about the patient's long-term quality of life.
And this philosophy is so critical because, when you really get down to it, the surgery isn't just about the technical act of removing abnormal tissue. It's about what that removal makes possible for the person.
And that right there is the why. Why go through all the trouble of renaming things, of creating new classification systems, of developing these complex procedures? It all comes down to this: allowing a child who was once held back by pain and couldn't move properly to finally be active, to play, to dance. It's about taking that flawed blueprint and turning it into the foundation for a full and active life.